Hello, everyone. This is Dr. Susan Hudson with another episode of Fertility Docs Uncensored, and I am joined by my amazing, delightful co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas,
Hello.
and Dr. Abby Eblen from Nashville Fertility Center.
Hi, everybody.
And we are pleased to be joined again by Dr. Mark Ratner. How are you doing, Mark?
I'm doing good. How are you guys?
Awesome.
Good.
Awesome. Mark is a board certified urologist and he is chief science officer at Theralogix. And today he is going to share some information with us about inositols and PCOS. But we wanted to kind of see if you had an update on any of your genealogy stuff that you were talking about last time you were with us.
Well, it's a lot of fun to do genealogy. And after you've done sort of like the basic family tree, which I've been working on for close to 30 years, since my first kid was born, then you start getting down, you go down these rabbit holes, and yeah, you can get really sort of down deep. And then the genetic component of it, the genetic genealogy aspects. Anybody who goes on, say, Ancestry DNA and does their DNA, they're going to send you a list of all of these individuals who are your cousins. And 95% of the names are like, I have never seen that name before.
Right.
So what crazy piece of information? I'm sure if you've been working for 30 years, you found something really very odd about your family.
People you're related to. My mom does genealogy, and so like we've got a few people that I'm like, ooh, that's kind of cool, I mean, who are some famous people you're related to?
I'll tell you, somebody that I went to medical school with, who I'm still in touch with, he during medical school was a sperm donor, and I had never talked to him about genealogy before. And then about, I don't know, a month or two ago, I just got into a conversation and I said, hey, have you ever done your DNA? He said, I won't do my DNA. I said, I figure it's like like big government privacy, your DNA is out in the world.
Yeah.
And he said, you remember I used to do sperm donation down in New Orleans. We went to Tulane Medical School. And he said, I won't do my DNA. And I told my kids they can't do their DNA. And I gave it a moment's thought. He said, I have no idea how many siblings they've got out there. Yeah. So that was sort of a revelation to me. I was really kind of puzzled by that. I mean, I understand that he's got concerns. But there's probably a lot of people out there that kind of want to know who he was, right?
Everything has really changed in the field. I mean, now the donor consents are very different of, hey, there's going to be multiple children. These are the ASR guidelines of you can have, I think it's 25 children per 750 population, 750,000 population. And so the numbers are much different than what people think they are and what you feel like they should are. But when you consider the size of the world, that's how they determined all of those numbers. So
very interesting. Yeah. I mean, it's back then it was just a way to pay his rent.
Yeah. So Mark, what's something interesting you found out about your family that you didn't know about?
Boy, these are deep, dark secrets.
Yeah, give us the deep, dark secret. That's what I'm asking. What are the deep, dark secrets?
Let's see. Deep, dark secrets. I found second cousins who, actually, they were second cousins of my parents who had been in the, what's called the HOA, the Hebrew Orphans Asylum of New York. Because in like I don't know what it was, 1910 or something, their father had died and their mother couldn't, and it wasn't truly that you were an orphan. If your parents or parent could not financially take care of you, they could put you there. And so online, they now have all of the registration papers
Wow.
all these kids, and they called them inmates, which was
Oh,
like,
how
it was
awful.
terrible. It was like,
awful.
oh my God, that was just wild. So there was that. There was let's see. My wife's grandfather had a brother who spent 2 years in New York State prison for
Mm.
for robbery. I found his prison records. There's all kinds of crazy stuff that you find. That was like her, I guess her great
My
great uncle or something.
my
Yeah,
mom does my mom does a lot of ancestry, and on my dad's side, we are somehow related to Helen Keller.
Oh, wow.
really,
That's one of my favorites. That's one of my
that's
favorites.
great.
Like,
Have you ever watched the Finding Your Roots on PBS?
Yeah, I think that is so, I love watching that show. That's
Oh,
great.
it's a terrific show. Yeah.
Yeah.
And Skip Gates is just really good at it. He's been doing it, like 10 years he's been doing it. And it's oftentimes very moving to sort of watch these people learn about their ancestors.
it is.
And the other thing, and I'll not to drag this out too long, my oldest child, my daughter, she is actually a doc. She's an addiction medicine doc, and her husband is Black.
Mhm.
And I went to Lee, that's his name, and I said, "Hey, has your family ever done its genealogy?" He said a little bit. Kind of think we're from like North Carolina, that area. So, and by the way, he has a grandmother who's alive at 106, and
Wow.
his father's alive at 80. Okay. So I talked to them, I got some information from them, and I was actually able to trace back to the plantation owner who enslaved his great
Oh, wow.
great
Wow.
grandparents.
Wow.
And then I found because the guy who was the plantation owner, he was sort of a very prominent guy back in the 1850s and 1860s. And his great great grandson maintains a wiki page about him, about the plantation and about everything else. And so I actually got in touch with his great great grandson. And so it was a very
That's
moving. And then
interesting.
I kind of showed all of this information to my son-in-law and his family, and they were just flipped. They were
Oh,
flipped.
wow.
Yeah,
Huh.
it was
That's
an
interesting.
amazing thing. So yeah, sometimes
Wow.
You never know what you're going to find.
That's right.
exactly. No, exactly.
Well, let's go ahead and do a question, and then we'll
Sure.
get on to talking about inositol. And in honor of PCOS, we're going to do a PCOS question. So our question for today is, hi, I love listening to your podcast, so thank you for putting out all this information. My question is, what kind of adjustments are made to IVF for people with PCOS? I'm 28 years old who has PCOS. I've had a few IUIs with letrozole and they haven't worked. Now, my most recent one, we had 4 follicles, which were measuring 19 plus. My doctor about IVF mentioned they make adjustments for PCOS to avoid OHSS and other risks, but I was curious what the protocol was for patients like me. I've been incredibly nervous about the added risks for patients like me. Thank you.
That's a fabulous question.
That's a great question. Nobody's ever asked that
before.
question. That's a really good one. Yeah.
So things that we think about for PCOS, of course, there's a much higher risk for ovarian hyperstimulation syndrome, which is when the ovaries just go absolutely wild and productive in making their eggs. And there's much higher levels of estrogen and also a particular growth factor called VEGF. And that makes the blood vessels kind of leaky. And so you have fluid that goes from the blood vessels where it should be into the belly. And that leads to a whole bunch of problems downstream. So we're very, very cautious about avoiding this because while most or many IVF cycles have kind of an element of hyperstim to them because we're trying to get as many eggs as we want, we don't want to go overboard in it. And so when we're doing an IVF cycle with someone who's got PCOS, we try to be very mindful of the medication doses that we use, maybe be a little bit less aggressive than we would in somebody who's in their 40s, say.
So essentially what we're saying is we use lower dosages generally in people with PCOS.
Yep. And there's other medications that we'll use. Cabergoline is one that's very helpful that you use immediately after retrieval to help minimize the dose. And sometimes we'll use some additional GnRH antagonists. So the medications like Cetrotide that prevent ovulation, they have the added benefit of kind of shutting down some of this activity. So we try and get it to go back down as quick as possible. So there's a bunch of things that we consider as we're going through this.
Well, and the real key too, though, and you may have said this, is a lupron trigger at the end. So,
Yes.
I mean, everybody's hyperstimulated. I mean, like Carrie said, pretty much everybody's hyperstimulated. We want you to be hyperstimulated, but really the thing that shuts down true hyperstimulation syndrome, where you're hospitalized and have ascites, is a lupron trigger. And usually PCOS patients are great candidates for that. They do really well with it. The one other thing that I just anecdotally noticed too, that patients with PCOS, back in the day when we didn't push people quite as hard, for some reason it seems like PCOS patients, that you almost have to push them a little bit further than the average person to get their follicles a little bit bigger to make sure the eggs are mature. They tend to have a little bit higher amount of immature eggs. And so sometimes I'll add either HCG, little small amounts of HCG every day or every other day, or also an older medicine, human menopausal gonadotrophin, that has a little bit of luteinizing hormone in it, and that kind of helps with the maturity of the eggs for patients with PCOS.
I think those are the big things. And then, of course, we also use inositols
Yes.
to help minimize our risk of OHSS. But we'll get into the weeds of that in a few minutes.
Sometimes we'll also use birth control pills leading into the cycle to help get the cohort all at the same time, and actually to get a little bit of suppressive effect, because it's the one population where you're okay if you don't get absolutely every egg that's growing, where it's kind of an advantage to not do that. So.
All right.
So one of this is an episode that we always look forward to recording, because it means that we get the latest and greatest what's going on with inositols, because supplements are such a they're such a huge wild world at times. And so when we get someone like Mark with us, we get to pick his brain. So for all of our listeners, this is a treat for us, because
we
this
learn
is like a mini conference that we get just the three of us to ask a zillion questions. So
this is awesome.
We're very appreciative that you're here, Mark.
We are.
Pressure's on. I'm gonna do my best.
Mark, let's start off with the basics. What exactly is an inositol?
Okay, so inositols, it's actually a class of compounds. Technically, what they're called are sugar alcohols, and people have probably heard of sorbitol, mannitol. Those are also sugar alcohols. So inositols are found in fruits and vegetables. You know, we get about 1,000 milligrams a day in our diet on average in the United States. But there are actually 9 different inositols in this family of compounds, and 2 of them are very special, and they're very important because they act as what's called second messengers for certain hormones in the body. The 2 that are important are called myoinositol and dechirioinositol. And when we say second messengers, what that means is when a cell has a receptor on its surface, and the hormone comes along and binds to that receptor, the receptor has to release compounds into the cell so that the hormone has its effect. And we call those compounds that get released second messengers. And it turns out that the inositols are second messengers for 3 very important hormones: insulin, thyroid stimulating hormone, and FSH, follicle stimulating hormone.
These are some big ones in our world.
Yes, absolutely. And so about 25 years ago, science was sort of realizing that the inositols play this important role. And a study was done, it was actually done in Virginia, to see whether or not supplementing people who had, I think it was it was PCOS patients at first in 1998, with inositols, whether that could improve their PCOS symptoms. And they used, at that point in that study, they only used dechirioinositol, and that was actually published in the New England Journal of Medicine. So this was, a big deal. And the interesting backstory is that study was funded by a drug company that thought, oh, we're gonna make this into a prescription drug. Okay. But because of the regulatory picture, it's a natural compound that we get and find in our fruits and vegetables. You can't really patent that. Okay. And
Interesting.
they were hoping they would find a way. They didn't find a way. And so that company said, okay, we're not going to fund this research anymore. And so what happened was inositol sort of fell off the map for a number of years until the Europeans started doing research. And they started publishing studies about 2006, 2007.
So why are inositol so important? What do they do as a second medicine?
I'm gonna piggyback on that before you answer.
Okay.
If you can answer that in relationship to insulin, thyroid hormone, and FSH.
Okay. All right. So the real issue in PCOS is insulin action, because a very high percentage of women with PCOS have what we call insulin resistance. It's probably as high as 80% in women who have high BMI. It's a little lower in women with lean PCOS. And there's a lot of discussion these days about maybe that's actually a completely different sort of
pathophysiology.
Yeah,
exactly. But nevertheless, insulin resistance is what is so important in many women with PCOS. And so what happens is this. Each one of the tissues in our body has a specific ratio between the myo-inositol and the dechiro-inositol that's optimal for that tissue. And so in the peripheral tissues, like muscle, fat, we need a higher percentage of dechiro-inositol than myo-inositol. In the ovary, it's exactly the opposite. We need more myo-inositol than dechiro-inositol. And what happens in PCOS is the ratios get all out of whack. And that's been very clearly shown in studies that were done 10 years ago. And so the purpose, let me just finish, the purpose of inositol supplementation is to try and rebalance those ratios. I'm not quite as conversant in thyroid stimulating hormone and its action, but it is very involved in FSH signal transduction. So in other words, for the follicle stimulating hormone to stimulate follicular growth in the ovary, it has to release second messengers. And those second messengers are primarily myo-inositol.
Gotcha.
When you're supplementing, and you're supplementing both dechiro and myo-inositol, do you give them both, and then whatever tissue happens to need one of them takes it, or how does that work? I mean, it sounds like our bodies are kind of fighting against each other. But
no, great question.
Supplement, does the right part of the body take what it needs?
Great question. So in normal individuals, the ratio in the blood, in the serum, between myo and dechiro is about 40-1.
Ooh, okay.
Say that again. The ratio where?
The ratio in the blood,
blood.
is about 40-1. That's a serum, and so what you're doing when you supplement myo and dechiro together is you give it in that ratio. You basically try to provide a little bit of dechiro, that's the one, mostly myo.
So does that mean that, what do you normally find in fruit? Because I can see how a lot of our listeners are going to go, well, I love fruit.
I'm going to eat fruit.
A ton of it.
Yeah.
Why do I have to take an extra supplement when I can put this in my diet in a way that's socially and medically acceptable?
The fruit and vegetable form is myo-inositol. Okay. The dechiro, I mean, I don't want to get too deep into, I don't want to bore everybody with
the basic science,
the biochemistry. But here's the bottom line is this: our body makes the dechiro that it needs from Myo.
Maya.
Okay.
Okay. So if our
and the
body
way,
isn't working as well as it should, we don't have the right proportion of D-chiro, so we're trying to help give a little crutch.
Overload more,
Yeah.
give more.
So what happens is there's a special kind of enzyme, which is called an epimerase enzyme, and it's the enzyme that converts myo to D-chiro. And in the peripheral tissues, okay, where you need a higher percentage of D-chiro, there's a problem with the epimerase enzyme. That's the root cause of insulin resistance. There's a defect in the epimerase enzyme in the peripheral tissues. And so
Why
you
can't we
don't get,
supplement the epimerase enzyme?
What, say it again? What?
Why can't we supplement that enzyme?
And why can't we just take D-chiro instead of myo?
Okay. You can't supplement the enzyme unless you were to give it, it's a protein. So if you took
It's
it by
kind of
mouth,
like MTHFR. I think of it like folic acid and MTHFR. You can't really substitute the enzyme, so you just have to give more of the substrate, right?
pretty much, yeah. I mean, to give an enzyme as a treatment, you'd have to give it parenterally. In other words, either by intravenous or injection.
Okay.
Because if you take it by mouth, it breaks down in the stomach. The acid in the stomach breaks it down. So why shouldn't we take just D-chiro? Well, that was the first attempts at using inositols, was pure D-chiro. And what they discovered was if you give too much D-chiro, it hurts the ovary. And here's the second piece of it, okay? When somebody has insulin resistance, most people are familiar with type 1 diabetes, where somebody has to take insulin injections. That happens when the pancreas basically has either completely shut down or has stopped making enough insulin, okay? So when that happens, what happens is that the blood sugar level builds up in your blood, okay? We call that hyperglycemia, right? But the insulin can't be made, so you just end up with hyperglycemia. In insulin resistance, what happens is because the ratio of D-chiro and myo is out of whack, blood sugar cannot be brought into the cells, and so you get that same elevation of blood sugar. You get
So you have high blood
hyperglycemia.
sugar, but your cells aren't getting the sugar that they need.
Your cells are not getting the sugar they need, but what happens is your pancreas says, oh man, look at all this extra sugar in the blood, okay? We need more insulin, okay? And so when somebody is insulin resistant, what happens is their pancreas is pouring out extra insulin, and they get not only hyperglycemic, that's the too much sugar, but they get what we call hyperinsulinemia, where their insulin levels are really high. And this is where damage to the ovary is done, okay? Because when insulin hits the ovary, it makes the theca cells produce testosterone.
Testosterone, yeah.
Okay. And so this is sort of a chain reaction that's occurring. And it all starts with that bad epimerase enzyme, which leads to insulin resistance, which leads to too much insulin in the blood, which leads to the ovary making testosterone. So all of those symptoms that women with PCOS get, hair, skin, weight issues, those are largely due to the testosterone, okay, that's being produced by the ovary. So the goal is to reduce insulin resistance, which is why metformin, for women who've had PCOS for many, many years, the standard approach was to use metformin, which is a prescription medication originally approved for type 2 diabetes, which is the kind of diabetes where you have insulin resistance. It's not that you don't have enough insulin. Your body's making the insulin. The cells can't respond to it because the second messengers aren't working properly. And so metformin has been, for many, many years, the first treatment that PCOS patients would be given. Yeah.
Yes.
But
so is this a situation where if some is good, more is better? Meaning, is this something where even patients who aren't affected by PCOS can benefit by this? Or is this something where more is not more and more is actually worse?
So there was a really interesting study published about 3 years ago. It came out of China, and they looked at 4 responders. These were non-PCOS women who either had low AMH or low antral follicle count, and they randomized them to either inositols or, I'm trying to remember if it was no treatment or placebo. That's an interesting issue because a lot of the studies that have been published, especially out of Europe, have not had placebo arms.
Placebo groups.
But that's a side issue. But the bottom line is that this study showed that even in poor responders, supplementing them with inositols improved the number of eggs that were given, that were retrieved, fertilization rates, it reduced the miscarriage rates, and clinical pregnancy rates were like statistically significant.
I got a question.
Was that independent of obesity status?
I don't know if they controlled for obesity. I don't really know. But these were non-PCOS patients. This was just poor responders.
Okay, so metformin, you mentioned that. A lot of these patients that have PCOS, like you said, are on metformin. My question is, can they take myo-inositol with it? Is there a risk from that? And what dose do you recommend?
Of inositol?
Myo-inositol,
Yeah. So yes, they can combine metformin and inositols, and there's actually a couple studies showing that the combined effect is better than either one separately.
Because you're working really kind of at two different levels, right? The insulin level and then the second messenger level.
Right. I mean, well, the mechanism, you mean the mechanism of action, you're right, is
different for both. Yeah.
The two. And then the interesting thing is that in the supplement world, there are even more insulin sensitizers. What we call metformin and inositols are insulin sensitizers. Okay?
Yeah.
Basically, what that means is they are reducing the insulin resistance by making the cells, the body cells, more sensitive to insulin.
So what dose of myo-inositol would you give them?
So we have obviously our product, which is called Ovasitol. It's 2 grams of a 40-to-1 powder mix twice a day.
Okay.
So that's 4 grams in the total during the day, in that 40-to-1 ratio.
I have a question. So a lot of our patients or people who are wanting to become our patients nowadays, when they come into their offices, they're now on GLP-1 agonists. So things like Ozempic.
Yeah, great question.
These things are helping people lose weight, meet BMI cutoffs, get in better physical condition to go through the IVF and pregnancy processes.
Right.
Is there any concern about using inositols with these GLP-1 agonists?
I would probably have to say, I don't think anybody knows yet.
Okay.
I think the studies have just not been done. One of the things that's sort of interesting about studying supplements, and inositols are non-prescription, they are over the counter. It's a very challenging process. Here in the States, and I will say we're actually participating at this point in 2 clinical trials with our product. One of which is up at Penn State Hershey. Rick LeGros is the principal investigator. The other one is at the University of Oklahoma. And the Oklahoma study is very interesting. They're doing, both studies are in PCOS, but it's the Oklahoma study is letrozole plus placebo versus letrozole plus inositols.
Oh, that'd be interesting.
Yeah, and they're doing, I think, up to 5 cycles of ovulation in IUI. Anyway, there's that, and then the LeGros study. So the reason why those kinds of studies, where like Ozempic and inositols, or the reason they're hard to do is because most couples who are seeking fertility assistance, they're not interested in placebo. Okay.
Yeah.
I mean,
unless you promise 6 months of treatment, 6 months of, flip-flop the groups or something where they both get treatments.
And the big issue is, so here's, I mean, and I think we talked about this the last time we met, CoQ10, okay? The reason why it's almost impossible to do a CoQ10 study, a good CoQ10 study here in the United States, is really 2 things. The first is a couple that's doing IVF or IUI, and they're trying to conceive, if you give them a consent form that says there's a 50-50 chance you're going to get placebo, and they know that down the street or online or on Amazon, they can buy CoQ10, it's like, thanks anyway, I think I'll just go out and buy that if you think it might help, okay? That's one reason. The second reason is because these are not drugs where the pharmaceutical company gets patent protection for like 20 years.
There's not the financial incentive for the companies to actually do the studies.
Yeah, exactly. And I mean, these studies, what's the end point that matters? Okay, the end point that matters is live birth, right? Okay, yeah. But to do a study where that's the end point, typically you need hundreds of couples.
A lot of years too, probably.
A lot of years, a lot of money. And so it's very hard to fund these studies. And it's like the original CoQ10 study that was done up in Toronto by Bob Casper. He had 4 clinics recruiting patients, couples, and it was CoQ10 versus placebo. And if they wanted, I think, 40 couples in the study. It was a pilot study. And after 2 years, they only got 22 couples.
Wow.
They just, it's just very difficult to do supplement studies in the fertility world. And so you need to get government funding if you're going to do a good study, or university funding. And that's what's going on now with inositols.
So I mentioned this a little bit earlier. How does the use of inositols during IVF help potentially decrease the risk of ovarian hyperstimulation syndrome, or OHSS, that we were mentioning earlier?
I would probably have to plead ignorance on exactly what the mechanism is there. But there is a study that it was actually a study head-to-head between women getting metformin and women getting inositols, and going through ovarian hyperstimulation. And the risk of OHSS was significantly lower with inositols. Okay. Now, none of them were getting Lupron triggers. I mean, it was sort of like,
back in the day,
the old days. Yeah.
It was a more standard protocol. And again, I'm not an REI, but my understanding is that with the modifications that you talked about earlier, the risk of OHSS in PCOS women undergoing IVF is much, much lower than it used to be. Is that the case?
Yes, absolutely. We rarely see it anymore. It's kind of like pediatricians seeing chicken pox.
Rarely do we end up with somebody in the hospital. My first week of fellowship, we had 2 inpatients for OHSS. They were both, it was back in the day when we did fresh embryo transfers, and they were both pregnant. And, once somebody's pregnant, there's minimum, there's less interventions that we can do and that type of thing. So yes, our world has definitely, in my opinion, changed for the better, because that was very stressful for everybody.
So I don't think I answered your question earlier about why not just give D-Chiro. You asked me that, and I think I got off on a tangent. So the answer to the question is because too much D-Chiro is already the situation in the ovary in PCOS. The ovary needs more. It's the ratio that matters. And what happens in PCOS in the ovary is you've got too much D-Chiro and not enough myo. And what you want to do is you want to restore mostly myo and just a little bit of D-Chiro in the ovary. The peripheral tissues need the opposite because of that faulty epimerase enzyme. So you can't just give D-Chiro. That's been pretty clearly shown, especially at high doses. Now, our product total dose of D-Chiro per day is 100 milligrams. The original study that was done and published in the New England Journal, I think that was 1,200 milligrams per day. Yeah. So high doses of D-Chiro, not good.
So how long do you need doses to be on board before, like if someone's going to do an IVF cycle, say that they know that they have to do IVF and they walk into your office knowing that, how long do they need to be on it in order to theoretically see some kind of effect?
Yeah, it's a great question that I think we only can extrapolate and guess at the answer, because there have not been studies where they do like, let's give it for a month, let's give it for 2 months, let's give it for 3 months, and we'll see
your best
guess? which works best, right? So I think it's 3 months. Okay. Most of the studies have used about 3 months of supplementation. What we do know is that you can see for women who are just not ovulating, if they're not getting their periods because of PCOS, and you start supplementing inositols, it typically takes about 3 months if they're going to have a response to restore ovulation. And the response rates are typically in the 60 to 70% range.
Wow.
So, but most of the studies have done 3 months. I'm not familiar with studies that have done significantly shorter periods of supplementation. Now, if you're looking at just symptom benefits, in other words, hair, skin issues, that a lot of younger women with PCOS may be focused on rather than, trying to conceive, that can take a little longer because those are the testosterone issues. And it takes a while for those to respond, maybe up to 6 months. But and very interesting. So we've been out in the marketplace now 8 years with our product. And about a year ago, we surveyed customers, and we just sent out like a few thousand emails to people who, had purchased on our website. So we had their email address, and we said, did you start taking Ovasitol because you're trying to conceive, or just because your PCOS issues were really bothersome to you? And it was 50-50.
Oh, that's interesting.
Huh.
Awesome.
Yeah. It's funny, years ago, about 8-9 years ago, there was the very first Inositol product that ever came into the States. It was actually from an Italian company, and they got a distributor in the United States, and they named the product Pregnitude. You may remember it.
Oh yeah, absolutely. I remember Pregnitude.
Okay. Yeah, and Pregnitude was just pure myo, I think with some folic acid in it.
Yeah.
And as we were starting to think about, creating our product, formulating our product, we started talking to people in the PCOS world, PCOS Challenge, and there's a huge advocacy sort of community that's really grown up. And what we heard was that, yeah, Pregnitude is interesting, but like college kids don't want a product on their counter.
Oh, that's true. Yeah. Oh, I hadn't thought about
that they have to explain to their friends. Why are you taking
yeah.
something called Pregnitude?
For moms.
Yeah, it sounds like a prenatal vitamin.
Yeah. So we tried for something that was a little bit more kind of down the middle of the road.
Yeah.
Yeah.
Funny.
So,
Mark, anything else you'd like to share about inositols or Ovasitol specifically? We've covered a lot today, so.
yeah.
It's been really helpful. I've taken notes.
Well, good. That's great. I mean, the PCOS community is, it's really grown dramatically in terms of I'm talking about the advocacy community over the past 7-8 years. And when we first started with our product, and we would go and meet at, fertility practices, and I did a couple of talks at like the Midwest Symposium and Pacific Coast, and I got like a lot of really blank stares. And the reason we kind of realized the reason was that most of the studies that had been published over the prior 10 years had been in European journals. And we started to jokingly call it NIH syndrome, meaning not invented here. So it was sort of like, and interesting story, one of my friends that I used to practice with, who was an REI, had done his fellowship with Dr. LeGros. And he said, oh, you got to talk to Rick about this inositol thing. And because Dr. LeGros is sort of like
he's the guy,
he's the guy. He published a lot of the
PCOS guy.
Studies, yeah. So my friend arranged a phone call and got on the phone with Rick LeGros. I don't know if you know him very well, but he's pretty plain spoken. And I started telling him about the science that we'd been reading in European journals, and he was like, I don't know, this was pure NIH syndrome. It was sort of like, if it's not published in the New England Journal, I don't know if I can.
It must not be so.
Yeah. So it was a very brief phone call. Not that brief, but it was polite. I said, thank you for listening. 6 months later, he got back in touch and said, okay, I want to try and get an NIH grant and study this. And so we worked on the protocol with him. And this is, the study that's now going on at Penn State Hershey. So we've made slow progress on the inositols and PCOS.
Yeah.
And I think the other thing that we've tried very hard to do is also to get the message out there that PCOS is, it's not just cosmetic issues or fertility issues. It's lifelong health issues, because it increases the risk for type 2 diabetes, for heart disease. And, so it's something that I think, and they say, different statistics, somewhere between 6 and 8% of all reproductive age women have PCOS. So, it's been an exciting and interesting trip for us down this road.
Thank you so much for joining us, Mark. We always learn so much when you come on. And as you can tell, we're always like, my turn.
Me.
Exactly.
So thank you guys for having me. Really
thank you. It was awesome.
We'll see you soon.
Very good. And to our audience, thank you for listening, and be sure to tune in next week for more. Also, be sure to subscribe and leave us a review in Apple Podcasts. We'd love to hear from you. We are also on Instagram, Facebook, and YouTube. So follow us, subscribe, and stay updated on all things fertility.
You can also visit fertilitydocsoncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We love episode ideas, and we want to know what you want to hear.
As always, this podcast is intended for entertainment, and it's not a substitute for medical advice from your own physician. We'll talk to you soon. Bye.
Bye.